And then BHA is just over 30 groups, member groups. And BHA is unique in that it is not cancer specific. Those groups represent all sorts of different bladder health issues and concerns, and include BCAN, also include Live UTI Free, as well as United Spinal Association. All right, so this gives you a flavor for what's to come. Here is our agenda. So I'm about to turn it over to Dr. Michael Shea, our esteemed AUA Research Appropriations Committee Chair. Then he'll kick it back over to me, and I'll provide some context, do some stage setting, talking about CDMRP, its background, why we care about it so much. And then we'll have each of our cancer groups provide their perspective on CDMRP programs, starting with prostate cancer, followed by kidney cancer, and then bladder cancer. And then at the end, time allowing, we'll have a Q&A. All right, Dr. Shea. So Dr. Michael Shea is a urologist at Children's National Hospital and a professor in the Department of Urology at George Washington University. He is board certified in urology and holds the certificate of added qualification in pediatric urology. Dr. Shea runs an NIH-funded research group and is the Associated Director for Science for the Sheikh Zayed Institute for Pediatric Surgical Innovation at Children's National Hospital. Dr. Shea is also our current chair of AUA's Research Appropriations Committee, or the RAC. The RAC's mission is to effectively champion for public, private, and philanthropic support of urologic research by energizing and synergizing with all stakeholders, particularly federal agencies, members of Congress, and of course, patient advocacy groups. And this is run through those three alliances we just talked about. Anyway, without further ado, take it away, Dr. Shea.
Well, welcome everyone. Thanks for being here today. So the AUA and Urology Care Foundation are very excited to be convening today's panel on this important topic. The AUA's mission as it pertains to today's webinar is to promote the highest standards of clinical care in urology through education, research, and the formulation of healthcare policy. So in other words, research is one of the central pillars underpinning our mission and at our core. So the Office of Research at the AUA is doing its part to promote urology as a specialty, to rising medical students, build the workforce pipeline, and recruit the next generation of urologic researchers. In order to ensure a landscape of robust research funding, opportunities is critical to attracting this next generation of urologists and urologic scientists. And it's also important to retaining early career researchers currently in the field, and the federal government plays an enormously important role in this. NIH agencies such as the NCI provide the most federal funding for biomedical research, followed closely by the Congressionally Directed Medical Research Program, or CDMRP, which is an umbrella program made up of more than 35 disease and condition-specific medical research programs that are all housed within the DoD. The CDMRP is the focus of today's discussion. Specifically, we'll be examining the CDMRP programs that fund urologic research and how these programs meaningfully incorporate the patient voice through consumer reviewer panels. You will hear more about what these opportunities look like and what they mean to patients throughout today's briefing. Finally, it's important to highlight, particularly in my role as chair of the AUA Research Appropriations Committee, that CDMRP programs are an excellent investment. So these programs have strong track records when it comes to funding high-risk, high-reward research that has led to breakthrough advancements in patient care. Our academic and community-based urologists rely upon innovations in care that come about through CDMRP-funded research, and countless patients have benefited as a result. Now I'm going to turn it back to Vanessa to provide additional background on CDMRP and its features.
Thanks so much, Dr. Shea. Okay, so CDMRP comprises 35, more than 35, I do believe it's 36 now, disease or condition-specific medical research programs. These are housed in Department of Defense. All of these programs, importantly, has a tie to military health. Also importantly, and we'll talk more about this in the coming slides, these programs are non-duplicative with NIH agency research programs. So that's something to bear in mind along the way, that CDMRP is a separate animal unto itself, a separate engine. So as I said, it comprises 36 different individual disease-specific medical research programs. And importantly, these programs are funded annually through the Congressional Appropriations process. They are funded as line items. And that's great for us as advocates because it means we can really appeal to Congress to affect how much funding we're getting in any given year. Whereas with larger agencies or different funding mechanisms, say NIH, NCI, that agency is given a top line funding amount, and how it's divvied across cancer types is an agency level decision. CDMRP is different because Congress has assurance that whatever they allocate, however much they allocate to a particular CDMRP program, that those funds are going just to that program. So from the House of Urology perspective, we are the AUA, of course. We have 3 programs of interest. And by 3, I really mean 2. And I'll tell you why in a minute. We have dedicated CDMRP programs for prostate and kidney cancers. These are huge, and we are organizing to get funding increases in the current appropriation cycles for these dedicated programs. Currently, bladder cancer receives funding under a CDMRP program that's dedicated to peer-reviewed cancer research. So this is a little different, and we'll talk about this in the coming slides. But bladder cancer, the point of the story is that bladder cancer does not have its own dedicated line item. Rather, it gets a portion of this larger pot of funding under CDMRP. So to pull back for a second, all CDMRP programs have lots of distinguishing features. And this is really by necessity. They want to be sure that they are non-duplicative when it comes to NIH. So one such distinguishing feature is that CDMRP programs fund high-risk, high-reward proposals. These proposals are often ineligible for federal funding from NCI, NIDDK, from other federal sources, the VA, any of our NIH agencies. So this is unique. As a result, CDMRP has turned out a lot of really interesting, neat innovations because they are willing to take more of a chance. The last nugget there, CDMRP funded research is often translational research. For patients, this is where the rubber hits the road. You know, I've been in this space a long time. I'm sure lots of you have. And in advocacy, you know, we dispatch patients to go and to ask for NIH funding, to ask for research funding. And then sometimes there's this feeling of, well, wait a second, do we ever feel the benefits of these funds that we're advocating for? And, you know, the truth of the matter is that the process of discovery is long, sometimes decades long. It can take a long time to bring a product from lab bench to bedside. So CDMRP is unique in that incorporated in its mission is to emphasize translational research. So this translational research is further in the pipeline. It's closer to the point of realization for today's patients. And again, this is across all CDMRP programs. So our established prostate cancer and kidney cancer programs, as well as that larger peer-reviewed cancer research program. All right, so now we're going to walk through each of the 3 programs that do fund prostate, kidney, and bladder cancers. So to kick things off, we have the PCRP. So this is the Prostate Cancer Research Program. It was established in 1997, so it is the longest of the 3. And last year it was funded at $110 million. This year, the PCIA, with zero at the helm, is requesting a $10 million funding increase. But a couple of things to highlight on this slide. So the first is NCI remains the primary funder of prostate cancer research. So you can see the differential there. NCI, and there's always a lag in when NCI data is available, but NCI funded prostate cancer research at $239 million in fiscal year 2018. Of course, that is more than twice as much as CDMRP. But again, to return to the point in the earlier slide, CDMRP is funding edgy, unique things. These are non-duplicative funding mechanisms. To give you a flavor for that, if you look at the graphic there, you can see some of the biggest blockbuster hits. CDMRP has been part of bringing these drugs to market in the prostate cancer space. A lot of you probably recognize these drugs. All right, shifting over to kidney cancer. So the kidney cancer research program is a little bit newer. It was established 10 years after the prostate cancer research program under CDMRP. It was established as part of fiscal year 2017 appropriations. And a couple of things to highlight on this slide. You can see through the bar chart here that NCI for a long time was the primary funder for kidney cancer research. However, KCRP, the CDMRP Kidney Cancer Research Program, has grown a lot funding-wise and now displaces NCI. So roughly, and this is all ballpark because again, NCI data is not available, in real time. But the point is that both funding streams give kidney cancer probably about $50 million a year. NCI was at $51 million in fiscal year 2018. And I raise this point because it's really, that's a huge thing. Typically, when it comes to cancer research, NCI is the primary engine for all things cancer research in this country. So this is a unique circumstance, and it really goes to show and speaks to KCRP's success, its track record, and its unique model. Alrighty. So last but not least is bladder cancer. So bladder cancer is kind of orphaned, right? Because it does not have its own dedicated program. Rather, it receives funding under the peer-reviewed cancer research program that's part of CDMRP. Couple of things about this. This is you're given a top line funding level and you compete against 19 other conditions. And this list will change from time to time, but for last year, this was the list of eligible topic areas under the peer-reviewed cancer research program funding pot. So it's tough, right? Even though bladder cancer got $8 million, a little bit less than $8 million of the $130 million allocation in fiscal year 2020, it had to compete against 19 other topic areas to get this funding. And importantly, that funding allocation is neither earmarked nor guaranteed. So BHA, and really with BCAN at the helm, but we are organizing this appropriation cycle to change that, to parse out bladder cancer from this larger funding pot and to give it its own line item. This would lock in a funding level. This would also give Congress more control and assurance that they know when they're allocating funds for bladder cancer that it is going just to bladder cancer. And this is especially important, and it gives you a preview for what's to come when we have our BCAN speaker, Dr. Chisholm, speak later on in the briefing. But bladder cancer also has a renewed importance in the sense that there is now so much evidence such that the National Academy of Medicine issued a report that Congress acted on to tie bladder cancer to exposure to toxic herbicides and specifically Agent Orange. So as a result of this evidence that has amassed over the years, Congress and the in the FY 2021 National Defense Authorization Act required bladder cancer be added to the list of presumptive eligibility conditions to receive VA benefits on the basis of this link. As I said, Dr. Stephanie Chisholm will be talking more about this from BCAN. So just to give you a flavor. But to pull back for 1 second, another thing that really distinguishes and what sets things up for the next panelist, the CDMRP programs, are these consumer review panels. So, you know, a lot of research initiatives from federal agencies and elsewhere, private research initiatives too, they talk a big game, and it's very well intentioned, right? About incorporating the patient voice. And CDMRP is unique in the sense that they are walking that talk. They have done that in a very beautiful way, a way which seems to really satiate patients and provides them a meaningful outlet, and also gives them an edge when it comes to research review. And so what does this look like? The panelists to come are going to describe it more as they have firsthand experience. But just very quickly, one thing to highlight is in the context, in the context of consumer reviewing, you don't have to necessarily be a survivor or a disease or a patient of that disease. You can also be a caregiver. So you can see the qualifications here. A consumer is a patient, survivor, family member, or a caregiver of a person living with a disease, injury, or condition. So we have all of our 36 CDMRP programs have these consumer review panels. As I said, they've been a great outlet for patients to engage, and also fruitful from the DoD programmatic perspective. So I'm about to turn it over to Allie, who's going to introduce one such consumer reviewer. But first, to give Allie an introduction. So Allie is a seasoned government relations professional. She is currently the Vice President of Government Relations and Advocacy at Zero Prostate Cancer, where she serves as the voice of prostate cancer patients and their loved ones in Washington, D.C. and state houses across the country. Ms. Manson leads the effort to end prostate cancer through policy by focusing on research, access, and awareness, especially for those at highest risk of the disease. Prior to Zero, she worked at the American Optometric Association, representing the concerns of doctors of optometry and their patients before policymakers, and Prevent Blindness, the National Coalition of Healthcare, and National Rural Health Association. Allie, take it away.
Thanks, Vanessa. I am with Zero Prostate Cancer, new name, almost the same. We are the leading national nonprofit with the mission to end prostate cancer and help all those who are impacted. We do it in a handful of ways. Advocacy is tremendously important for us. We spend a lot of time supporting the prostate cancer research program. That has been hands down the most valuable investment in prostate cancer research at the federal level. We have seen in the last decade 7 new treatments for advanced disease and 1 new diagnostic tool. And we're very proud supporters of that program, as well as some prostate cancer activities at the CDC and of legislation that improves research coordination and increases access to prostate cancer screening. But if you'll go to the next slide, I always like to take just a minute or two to share about our patient support programs. We are deeply invested in providing public education, to fighting in favor of health equity. But on the ground, and I think this is what's so useful for patients, for folks around the country, we offer a couple of very valuable support programs. First, we have 0360. It provides comprehensive patient support, everything from navigating your insurance to looking into debt relief while under prostate cancer treatment. Anything a patient who's going through a challenging treatment time in their life might need. That's a wonderful program. It's incredibly active, and it can be found at our website, zerocancer.org. So please feel free to share that with anyone undergoing prostate cancer treatment who might be. We also know that peer-to-peer support is so important for individuals in going through their prostate cancer journey. We have our Us2 support groups that are around the country, both in person and virtually, allowing patients and their loved ones, their caregivers, survivors of lost loved ones, almost every permutation you might need, to get together with other folks who've gone through the same things they have, right? To offer one another support, advice, you name it. We also have our Zero Mentor program, which pairs men kind of like a dating app, right? Pairs men with like needs, like journeys with one another in order to provide individualized peer-to-peer support through that journey. So I just love to catch that up. These programs are all possible because of wonderful volunteers like the one you're about to meet. Vanessa, if you want to go to the next slide. Brian Jones is a Zero champion. He also just passed the 7-year mark for being prostate cancer free. He's a native of Philadelphia, but currently in Harrisburg. And he has been very active with the Pennsylvania Prostate Cancer Coalition, as well as with Zero. He's one of those mentors I mentioned in the program before, as well as a member of our Health Equity Task Force. Most importantly, for our purposes today, Brian has served as a consumer reviewer with the PCRP at DoD, and he's going to share a little bit about his experience.
Good afternoon, everyone. My name is Brian Jones, and like Ali had shared, I'm a loving member of the Zero Prostate Cancer Organization, and today I'm tasked with giving information and providing my testimony on the impact of the CDMRP program. And I think back to how I got connected with the CDMRP program. I attend the Zero Summits regularly. They're a source of a lot of information that I take back and implement in other organizations that I serve with, and also take that information and serve in the communities. So I waited about 2 years on, I guess, a waiting list to get involved with the CDMRP program. And once I was selected to be a part, I really learned a lot and have treasured that role ever since. My first year, I was able to sit on a task force that looked at, as a consumer reviewer rather, and looked at 10 different projects looking for grant funding, and just the science of it, understanding that, being able to talk to scientists from all around the country and sometimes even outside of the country about projects that they have going on that look to help men like me, and also downstream families that might have sons that might be impacted by prostate cancer moving forward. I fell in love with the program at that point because I saw the magnitude at which it could help serve not only me, but people all around the world. And thinking about the program, anytime I talk about the program, I always talk about how this is one of the most important decisions that I've ever made in my life, health-wise, since I was diagnosed with prostate cancer in 2015. I never thought that I would be serving in this capacity previously. My background is in pharmacy and pharmacy management. Being on that panel is something that I take very seriously. I prep for it all of the time. I look to enhance my skills so that I can better understand the science that's being broken down. I read through all of the notes as far as the grant applications, because I want to do the best job possible, because people's lives are depending on me and the work that I'm doing with this program as it's handed over to the scientists to figure out their end of it. I wouldn't be sitting here today if it wasn't for the people who came before me doing the work to make sure that I was able to be treated in such a way that saved my life and gave me another day to live, to be able to serve other people moving forward. I believe in the pay it back formula. The process of working on these grant applications, it might be viewed as some as tedious, but not me. I look at it, every word could represent a man whose lives could be altered and changed and elongated based on the work that's being done by these scientists. Just talking to them and hearing their stories and trying to understand how we feel as patients is very important to them. And I can tell that they're passionate about the work that they're undertaking to save lives. And I don't take that for granted. I'll give you a quick example. Last year, my wife and I celebrated 36 years of marriage. And during the time that the cases were being reviewed for grant applications, we were on a vacation where we took a week and we flew to Hawaii to celebrate our anniversary. During that time, I didn't want to fall behind. So I took my laptop and my legal pads with me on the flight and did work on the flights to and from, and also in Hawaii while I was on vacation, because I want to make sure that the quality of work that I'm presenting is good enough to be able to save lives and have an impact. So I don't take that for granted, whether we're on the beach, just relaxing and having a good time. I always found time to pick up my readings and pay attention to it, make notes and move forward, secured them in my luggage and made sure that they got back and was entered into the notes, into the information. I do ask questions when I don't understand things because, once again, I want to do the best job possible. During the panel reviews, everything works cohesively. People are doing their jobs, they're breaking things down and understanding it, they're giving scores and things like that. During this time, I haven't even probably met the majority of the people who are on the scientist part of this, but they welcome me in just like they would a family member whenever I'm logged in and being able to participate in this process. Like I said previously, this is one of the most important things that I'm currently working on. And I take pleasure in providing this service. And I wish that I could do this for the rest of my life. If my life ended tomorrow, I would die with a smile on my face, knowing that I was able to serve in this capacity on such a prestigious panel in this program. That's why I don't mind sitting across from legislators and asking them to sign on to bills that would provide $120 million for research for the CDMRP program and the other programs that Zero has put into place to serve men and families across this country. I don't take that lightly because I care about not only the people in my family and sphere of influence, but everyone else out there too. Because when I see them, I also see myself. The impact that it has over time. After debriefing and settling down after the panel is over, I usually take a day or two to just relax. Then after that, we're right into Prostate Cancer Awareness Month and going out and meeting men and their families in the community and thanking them for coming in to receive the free screening that many of the organizations that I serve with offer. And it's nothing like being able to tell them and encourage them, don't be dismayed. There are scientists and people all around the country working on your behalf through these programs to find a cure and other treatments that could extend their life and possibly save their life. I'm encouraged by it, and I would like them to be encouraged by it too. A lot of times it brings tears to my eyes to see these men and their families come in to have this screening done. The CDMRP program provides me hope, and I definitely extend that hope out to my fellow prostate cancer screeners and patients that have been walking in my shoes. So I don't take it for granted that I'm selected to be a part of this. I thank you for the opportunity to be able to speak about this prestigious program. And I love serving in this capacity once again. And please continue to do what you do. And if there's ever a way that I can continue to be a part of this or do any other thing to make sure that this work goes forward, please don't hesitate to ask me, because this is very important to me and our community. Last week, I was able to spend time with 36 peers from all across the cancer continuum. Many of them are part of the CDMRP program in various different cancers. And the one thing that we all have in common is our passion to serve our fellow man and humans across this country, and also our veterans, which is a very underserved population that need to have access to resources so that they can be able to have treatments and options for looking to extend their life and not be just pushed aside like we use them just for their service on the front lines. We need to enhance their lives and provide resources and healthcare for them so that the love that we have for them is shown and not have it look like we just use them as a pawn to take care of us and make it safe for us to live here in this country. With that said, continue on with the work that you're doing, and anyone within the sound of my voice, know that when you see me, you see 10,000. Famous quote that is one of my life quotes. We come as one, but we stand as 10,000. That's a quote by Dr. Maya Angelou. Last week, I was with 35 other people. So we come as 36,000 strong in a small room of 36 people. That's how much love and caring we have about the work that we do. A lot of it is volunteer work and highly worth it and valuable. With that said, I would like to close out my remarks about this proceed this program and know that my heart is in it and will always remain in it for the rest of my life. Thank you. Next up, I would like to introduce Reverend Dr. Walter H. Jones, who has been pastoring for over 40 years in our communities and making impacts in the people in his community and throughout the country through his ministry, his love for people, and his leadership developing youth programs. And his work is so profound that where he started at as far as impacting the lives of young people, that's the future of healthcare. The future of fighting cancer is to empower them with education, to allow them to move forward, knowing about screening, when to get screening, where to go for screening, and to know their risk levels. So without further ado, I would like to hand it over to Reverend Dr. Walter H. Jones. Thank you.
Thank you, Brian. That's Walter Johnson. And I am going to connect with you because you're from Harrisburg, Pennsylvania. I grew up 1 hour from you in Coatesville, Pennsylvania. So we have to talk. We have to talk. Welcome, everybody. I'm so happy to be here to share just a few thoughts about what we're trying to do. And it's so exciting to hear the passion that comes from others. We're all advocates for each other. I'm a big fan of Brian's cause, and Brian is a big fan of our cause, and we push together to try to make a difference in the lives of people that we know and people that we love. I was diagnosed with kidney cancer 15 years ago. Thankfully, it was early detection, and through surgical procedures, my urologist was able to save both kidneys, which work absolutely fine today. This coming Sunday, I will be 74 years old. I wouldn't be here had it not been for my doctor sending me for an X-ray with contrast that happened to reveal a spot on each kidney. Now, I say that to say this. I represent the Judy Nicholson Kidney Cancer Foundation in Jacksonville, Florida. Judy Nicholson was a happy wife, mother, and real estate executive in Jacksonville, Florida in 2007. Yeah, 2007. Absolutely fine. In February of 2008, Judy Nicholson fainted. Now, I want you to understand that she had previously been to a doctor for another situation in December of 2007, and they detected nothing. In 2008, February, she falls. In March of the same year, they had to remove one of her kidneys at the Mayo Clinic. By the October of the following year, Judy Nicholson passed away. And her husband, Nick, started this foundation along with some of her former co-workers. Then I came on the scene, I guess around 2016. At that point, kidney cancer was getting, I think, a $10 million appropriation, as Vanessa showed the slides, from Congress. I came on board with Nick, and my first trip with him was to Lisbon, Portugal. I think it was 2018, to attend the International Kidney Cancer Coalition. I had no clue what this was. Well, once arriving, I got my feet wet, and believe me, I met some of the most wonderful people you could ever meet from around the world. And many of them were kidney cancer survivors. Some still dealing with kidney cancer at the stage 4 level. As a matter of fact, I'll share something with you in a moment. So coming back, I was invited to participate in a panel to become a consumer reviewer. I had no idea what that was. I go to Washington, D.C. I live in Jacksonville, Florida. I go to Washington, D.C. and participate in this panel, not knowing anything. They give us a briefing and you just do what you're going to do. So we're given these proposals. These are scientific proposals. And without these proposals, there would be no advancement in research to get to the pills and the drugs and the treatments that are needed to save people's lives. By the way, in 2020, 180,000, doesn't sound like a whole lot, but if you're one of those numbers, it is. 180,000 people died of kidney cancer worldwide. Anyway, I'm looking at these proposals and I had to take a deep breath, and I was told to just take your time, go through it, but look at each proposal through the lens of the consumer. And as we do that, we try to figure out how the consumer is going to benefit from these proposals if they are funded. One of the questions that arises is it cost effective? And will it be available to people in all segments of the population? And many times, many things are not available to all of us. You have to be in a certain area or a certain income level or have certain insurance coverages to have access to some of these plans. You consider all of that as you write up your review. As Brian mentioned, you meet some of the best scientists. These are people who really, really care about others. Now, the Judy Nicholson Foundation primarily deals with patient advocacy. We deal with those who are caregivers, and we try to do our little piece to make a difference in lives as well. We have symposiums around the country every year. As a matter of fact, this past March 11th, last month, we had a Symposium of Hope in Miami, Florida, in conjunction with the Sylvester Cancer Center at the University of Miami. At this particular convention or symposium, I met a lady who was a stage 4, she had stage 4 kidney cancer. Her mother died of kidney cancer before her. Now she is dealing with so many different drugs, so many different treatments, but she's still here waiting on that one treatment that's going to turn things around. Now, as we push hard for 60 million this year, and as the slide previously indicated, we've been at 50 million for the last, I think, 3 years. Brian Lewis can tell you more about it than I can. 50 million. We're going for 60 million this year, and hopefully we'll get more. But I know you guys need more too. Everybody on this call needs more. Bladder cancer needs more. But we're going to get it. We're going to get it, and it is going to make a difference. Now, one area, before I move on, we're trying to get to early detection, as was the case with Judy Nicholson. Had there been some type of screening, and I heard Brian mention the word screening, we don't have anything like that in the kidney cancer arena. If we could take a test, a PSA, a blood test, some type of exam that would detect kidney cancer, it would save a lot of lives. So that's one of the areas we're really pushing to try to get some type of results where we can get early detection. And hopefully we'll get some proposals in the next go round that will push for early detection. Now, I'm going to pass it on. One of the areas that we don't hear a lot about is childhood kidney cancer. And our next presenter, Kathy, whose son passed away from kidney cancer, is going to share with her. She founded Joey's Wings, and I've been on a number of calls with her, a very enthusiastic person. I'm anxious for you to hear her. I'm going to turn it over to Kathy Liu right now. Kathy, go ahead.
Thank you. Hello, everyone. Thank you so much for the opportunity to share our journey and why it's important, why the CDMRP fund is so important for people with kidney cancer, including children and young adults. Next slide, please. This is my 10-year-old son, Joey, who was a gifted student. He played violin in the county youth orchestra. He was the award winner of Mastery Contest, very, very artistic child. During a physical checkup on his 9-year-old birthday, Joey was diagnosed with translocation renal cell carcinoma in 2013, which is a very rare subtype of pediatric renal cell carcinoma. Next. Upon his diagnosis, his tumors already spread from kidney all the way up to his neck. At that time, there was no standard treatment, and sadly, even today, there's no standard treatment for his type of cancer. He went through 2 major surgeries, 4 different oral chemotherapies, 1 IV chemotherapy, and radiation. Next one. So I started in 2013, I started petition from 6 drug companies pleading for the immunotherapy drug PD-1, PD-L1 for Joey, which was already available for adults, but not available for children. But sadly, all this petition was not granted. On September 4th, 2014, another immunotherapy drug, Keytruda, was approved by FDA. Joey started the off-label use of Keytruda. There was no major side effect from this drug, and his tumors in his neck, we can actually see, shrank significantly after the second injection. We had so much hope. However, his body was so exhausted, and the day before Thanksgiving, he passed away. The next day on Thanksgiving, we donated his 2 cornea. So I believe that my child is still, watching this world. Next. So 1 week after his passing, I started a foundation called Joyce Wings Foundation to honor his fight. We support research that focuses on kidney cancers affecting children, young adults, and promote advocacy and education for parents. So all the donation made is used toward the research and treatment options, parents support and advocacy for developing less toxic therapies to treat kidney cancer among children and young adults. Next. Before Joey's diagnosis, I didn't know children get kidney cancer. And it is shocking that there are 11 types of childhood kidney tumors. And the incidence of renal tumors is increasing among children and adolescents in the US. As you can see here, about 11 types of childhood kidney cancer. Many of them still don't have standard treatment plan, like my son's tumor, translocation renal cell carcinoma, U1 sarcoma of the kidney, and primary renal synovial sarcoma, rhabdoid tumor of the kidney, which happen with babies. All this, they don't have a standard treatment plan. You can imagine the desperation and hopelessness of those parents when they hear, your child has a rare cancer and there is no standard treatment option for them. Next. So about 5% of all cancers in children are Wilms tumor. Wilms tumor is the most common type of kidney cancer in children. So the 5-year survival rate for all the pediatric kidney cancers is around 50 to 75% if the tumor is found early. However, when it's spread to the lymph nodes, with my son's case, the survival rate drops to only 10 to 15%. And the research funding has helped these Wilms tumor patients. And most of the Wilms tumor patients do survive. However, there's very little research for pediatric renal cell carcinoma. And majority of pediatric RCC research here in Europe is funding by foundations like us or patients' families. It's very sad and it is wrong. Next. When we see childhood cancer and adult cancer, they are very different in many ways. For example, pediatric renal cell carcinoma, they differ from their adult counterparts, not only in histologic subtypes, but also in the clinical characteristics and outcome. Children and adolescents are more likely to be diagnosed with a large renal cell tumor, or the cancer already spread to the lungs, liver, bone, or lymph nodes. Next one, please. And so the answer behind this is the children need better cancer therapies designed to fit their body. Yes, next. We are very grateful over the years. CDMRP research funding has granted the funding, the opportunity for study on translocation renal cell carcinoma, which is Joey's cancer, but there's so much need to be done. We need to research into the long-term side effects of treatments. children also need access to adult trials and new treatments. We need an international biobank that includes the sequencing to help understand this disease better. We also need international collaboration for these rare cancers. So all this cannot be done without the funding from CDMRP. Yeah, thank you so much. That's my sharing today. And if you have any question about the kidney cancer with children or young adults, feel free to reach out to me. Please welcome our next speaker, Dr. Chisholm. She's from the Bladder Cancer Advocacy Network. She will share her experience and her work. Thank you.
Thank you so much, Kathy and Vanessa, for inviting me to be here. The Bladder Cancer Advocacy Network was established in 2005 when Diane Zapersky-Qualley and her husband were really astounded by the lack of federal funding that was going to bladder cancer in all of the NCI and NIH research. There was very little going there. And they started the organization. We have been the premier bladder cancer patient advocacy group in the United States for 18 years. Our mission is all about providing education about the disease for patients and their loved ones, and also helping support. We have a new call center that we partner with Cancer Care, and patients can call to speak to a licensed clinical social worker and help and find help in their own communities. We do advocacy and raise awareness every year. We host May being annual Bladder Cancer Awareness Month, and we do walks all over the country. Our goal this year is to raise $1 million to help support some of the research that I'm going to tell you about in just a second. And since the very beginning, we realized, Diane and John knew that in order to really have leading experts in the field, they literally had to grow their own. So we started our Young Investigator Awards, where we're supporting the research of young or early career scientists and clinical cancer research investigators who have a commitment and real understanding about the treatment of bladder cancer. A couple of years ago, we added a Young Investigator Award that focuses on patient-centered clinical outcomes. So we're really looking to help improve the quality of life. And we do 3 to 4 of those awards every year. We added a new research award with our Career Development Award this year, where we're really helping to bridge the gap from a young investigator's scientific opportunities to someone who is more seasoned, with a $250,000 award that can be distributed over 3 years. And we're very excited that that first award went to Dr. Roger Lee at the Moffitt Cancer Center. He's definitely an up-and-coming leader in the bladder cancer space. Next slide, please. Our Research Innovation Award is very much like sort of a small scale CDMRP peer-reviewed cancer research program award, in that we specifically target and support high risk, high reward research, but not to that level that the federal government is able to support. We have a couple of awards that sometimes we give 2 a year, and they're $300,000 each over 2 years. So that's a very significant commitment for us as a patient advocacy organization, but certainly that's a drop in the bucket from a federal government budget. And we really do a lot to encourage that additional line item so that we don't keep having to go back and be at the risk of Congress saying, no, there's more important cancers out there, because what people don't realize is bladder cancer is the 7th most common cancer in the United States. And this year alone, 82,000 Americans will be diagnosed with bladder cancer. We were very fortunate this year to receive a $3 million gift from one of our board members to be able to support translational clinical trials. And we're very delighted to say that we were able to fund 2 unique awards specifically to help advance non-muscle invasive, which is the bulk of our bladder cancer patients have non-muscle invasive disease, which has a very high rate of recurrence and is very expensive to treat. So we're very excited about seeing what that science is going to bring over the next 3 years. Next slide, please. As I mentioned, bladder cancer is the 7th most common cancer overall, but in our military population, it is the 4th most common. And that's significant in that there's so many things that our veterans are exposed to. We have been on the peer-reviewed cancer program since 2016. And over the last few years, they have funded over 55 different awards. Just last year, $6.8 million was given for 5 cancer research studies for bladder cancer research, which is very gratifying. But we would love to be able to do more. We host webinars to inform our research community about this opportunity and encourage them to do that. And you wonder why veterans and why there's relevance to bladder cancer, but anything that a veteran is exposed to gets into their bloodstream, and ultimately after going through their kidneys, it sits oftentimes in their bladders for a while, and they're exposed to many different things that could alter the lining of their bladder or the muscle layer of their bladder to the point where cancer becomes more likely. So if I can get the next slide, I just wanted to highlight a couple of those things. We know that Vietnam era veterans are exposed to a rainbow of herbicides that were used, including Agent Blue, which has high arsenic content, and Agent Orange, which are both recognized as highly toxic. We know that bladder cancer has a presumptive link to Agent Orange exposure. Not as many people know about Agent Blue, but it is one of those herbicides that was used. And we're really grateful that we're able to get our veterans treatment options through the VA because of their exposure. But we also know that those who are dealing with chemicals in their workplace, environmental, occupational chemicals, are at greater risk of developing bladder cancer, particularly the PFAS chemicals, the man-made chemicals that are often used in military firefighting foams. They've also contaminated the air and groundwater at military bases. For instance, Camp Lejeune is known for not only the veterans and active duty that have been stationed there having increased rates of bladder cancer, but the families that lived on the base as well and were exposed to those toxins certainly put them at additional risk. And then when you look at modern warfare, we encourage patients who have developed bladder cancer and who have been in Iraq and Afghanistan to register for the burn pit registry so that we can track and find out more about the risk for bladder cancer, which I'm pretty sure is out there. It just hasn't been documented in a very significant way yet. But we know that our firefighting community, our first responders, another group of brave heroes, have elevated rates of bladder cancer because not only what they might be breathing in, but the very things that settle on their clothing and then they're up against their skin may be absorbed into their bloodstream and ultimately sit around in their bladder, causing damage and damaging the chromosomes that might make them weaker and more susceptible to cancer developing. So those are the reasons why we really do support the CDMRP funding and do request that additional $8 million line item so that we can just be sure that we're always going to be in that research community that is federally funded and will always have a presence. And I thank you so much.
Thank you, Stephanie. That was wonderful. And thank you to the rest of our panelists. What great, compelling presentations you all gave. I think, if there are 2 takeaways from today, the first is that CDMRP is a powerful engine. It has its spot. It is expanding horizons. It's bringing forward new discoveries, and it is worth its salt and then some. But if there were another takeaway, it would be that it's about time bladder cancer get its own CDMRP program. The evidence showing the tie to military health has amassed, it's indisputable, it's undeniable, and it's a natural next step for Congress to take after adding bladder cancer to the list of VA presumptive eligibility benefit conditions. But now we have time for 1 or 2 questions, and we've gotten a few. in the chat box. The first that we've gotten is there a dedicated CDMRP program for benign urologic research? Short answer, no, there is not. If we had our druthers here at AUA and UCF, there would be, but there is not. I will say what we are trying to do on our team here at AUA is figure out all of the different funding streams that do support urologic research. I have picked up through press releases here and there that certain urologic research proposals have been funded through CDMRP. There are a few different sort of larger pots of money, right? One is the peer-reviewed cancer pot of money, but then there's also a peer-reviewed medical research pot of money that could really be applicable for any disease or any condition. And I do think that benign urologic research does pick up some funding that way. But short answer, no dedicated program at this point. The other question that we got in the chat was, Brian, you noted that it took you 2 years to get into the CDMRP Consumer Review Panel program. So this is a twofold question. Was the juice worth the squeeze? And that's my shortening this question, A. And B, did you try any other avenues for engaging in research as a patient?
It was most definitely worth the wait time to be able to get involved with the program. And if I had to do it all over again, I would. And secondly, no, I didn't go through any avenues to find other groups to advocate with, because I believed in the CDMRP program, especially because it serves our veterans. What I did in the interim was look to increase my skill set and knowledge of the science that goes around prostate cancer, blood biopsies, and things of that such, to make sure that I was ready to be able to be an active participant and bring something to the table.
That's a great answer. Thank you, Brian. And that brings us to time and is a great note to end on. We will follow up with a bundle of materials, including our speaker bios, along with a couple of other one-pagers. So be on the lookout for those items. And please don't hesitate to reach out to me. You can see my email right there on the screen, bkramer@aua.net. If you have any afterthoughts or follow-up questions. And special thanks to our esteemed panelists. Bye, guys.
Bye, thank you.
Bye, thanks, Kathy.
Hi, Vanessa. I have
Yeah.
a question. Let me
Okay,
see.
hold on one second. I'm gonna, whoops.
Yeah, I probably will email. Dr.
Actually,
Shea.
Kathy, I want to talk to you. What's your schedule like tomorrow?
Tomorrow, I'm very flexible.
Because I want to talk to you about, so, Wilms tumor gets, actually, Kathy, let's take this offline because they need to shut